Jan Bartonicek here from Prague. He's a lot of trauma experience and a longtime member of the Association for the Rational Treatment of Fractures. He's going to speak on his experience with the 95-degree angle blade plate in the treatment of distal femoral fractures.
So, Mr. Chairman, dear colleagues, probably the first osteosynthesis of the distal femur fractures was performed by Albin Lambert in 1906. Or 60 years later, AO introduced angle blade plate, which changed the operative treatment of distal femur fractures. However, the development of implants progressed up to locking plates, and these new implants should improve clinical outcomes. But is it a reality? Look at biomechanical studies. Zlovotsky found that LIS provides greater fixation strength in axial loading and less fixation strength in torsional loading. And the findings of Higgins were similar. Henderson recorded over a rate of healing difficulties in locking plates up to 32%. Very interesting is study by Zlovotsky. He found the highest rate of deep infection in compression plating, but non-union rate was practically the same. The difference was very small. And fixation failure rate and secondary surgical procedures rate was the lowest in compression plating. Something is wrong. It means the clinical outcomes didn't confirm the theoretical benefits of locking plates. Look at principle of treatment of distal femoral fractures. This procedure includes 4 steps. The first, most important step is anatomic reconstruction of articular block. This step is implant independent and we need a good overview. The second step is reduction of this articular block to femoral diaphysis. It means restoration of length of distal femur and also its axial alignment. The problem in this step is metaphyseal comminution. The third step is also implant dependent, and it is fixation of, it is fixation of implant to articular block. This, as I said, this step is implant dependent, and it is relatively demanding in blade plates and relatively easy in locking plates. And the first step is the fixation of articular block with implant to femoral shaft, and the strength of fixation depends not only quality of the bone, but on the type of screws and also on effective length of the blade. As I said, the problem is a severe problem, is the metaphyseal comminution. It is a problem for reduction, for stability, and for healing. It is a general problem. It is a problem in LCP, also in angle blade. The solution is maximal preservation of metaphyseal blood supply. And in some cases, it is a biologic stimulation. It means primary or secondary bone grafting. Here we can see, on this case, we can see the importance of secondary bone grafting. Old lady with this type of fracture treated with condyle plate. 2 months after surgery, she refused cancellous bone grafting, and she came and started weight bearing. She came 6 months after surgery, and we can see loosening around the blade and some signs of healing. However, she again refused secondary procedure, and 2 months later, the blade got broken. And now my personal experience with angle blade plate, which started 25 years ago. It is my first case, patient with this comminution, fixation with angle blade plate, and result 1 year after surgery. For stability of fixation, it's important to insert the blade closely to medial cortex of medial condyle. This was polytraumatized patient. The surgery was performed 1 month after injury without bone grafting, and here radiologic result 11 months after surgery. In this case, we maximally preserved blood supply in metaphyseal zone and healing 1 year after surgery. And this is my last case, younger man, but alcoholic with severe osteoporosis, with previous fracture of proximal tibia, fixation with condyle plate, and result 4 months after surgery. And now a few special cases. Old lady after endernailing, typical injury 1 month after surgery, refixation with condyle plate, and radiologic result 11 months after refixation. In this case, the femoral shaft was occupied by previous surgery. We reconstructed articular block and fixed with condyle plate to femoral shaft and healing 9 months after surgery. Relatively younger man in this case, but alcoholic again with severe metaphyseal comminution, and here was necessary to impact the femoral shaft into articular block with shortening of 2 centimeters. However, very good healing within 5 months after surgery. This patient suffered bilateral injury on the right side, pylon and talus fracture. On the left side, this fracture, which was treated immediately after surgery without bone grafting. He started weight bearing with this result, therefore refixation with secondary bone grafting and healing 18 months after surgery. Lady after supracondylar varus osteotomy of distal femur for gonarthrosis, osteoarthritis of the knee, after fall, failure of fixation, refixation with condyle plate from medial aspect without bone grafting and healing 4 months after surgery. Also, this periprothetic fracture was treated successfully with condyle plate. Look, here we can see medial cortex, and this is the tip of the blade. Naturally, currently, we can use locking plates, but even locking plate may fail. In this case, this fracture with secondary fracture line in metaphyseal zone was treated with locking plate without bone grafting. 4 months later, the plate got broken, again refixation, again without bone grafting, and again after 4 months, the plate got broken. We changed the implant, we performed secondary bone grafting, and this is the result 3 months after surgery. It was the last week, and we will see. So, we can compare advantages and disadvantages of locking plates and angle blade plates. But the main argument of younger surgeon, main argument for LCP is that the fixation of LCP to articular block is relatively very easy. But it is a common problem because I think the younger generation has a lack of general experience with angle blade plate, not only on distal femur, but also on proximal femur in case of intertrochanteric osteotomies or in some special cases. But the successful treatment of distal femur fractures must be based on principles, must be based on general knowledge and skills, not only on implants. If you manage these principles, we can be successful. I would like to show you on this case, lady 60 years old, polytraumatized, pylon fracture, distal radial fracture, distal femur fracture, lateral condyle fracture, she was treated. Immediately after injury fixation, we perform restoration of articular block with leg screw and Kirschner wires, fixed with condyle plate, percutaneously insert this leg screw, and 1 month after surgery, we performed from short medial incision secondary bone grafting, and it is 1 month after grafting. Look on the very nice signs of healing. It is situation 8 months after surgery. At that time we removed arthroscopically this leg screw, and this is the result. 12 months after surgery, and this is the functional result 8 years after surgery, functional and radiological. So we can summarize, not implants, but the general knowledge and skills are the most important prerequisites for successful treatment of distal femur fractures. And if you manage these prerequisites, angle blade plate can still be a useful implant for treatment of some type of distal femur fractures. Thank you for your attention.
Questions for Dr. Bartonicek? How many people in the audience are still using blade plates to treat distal femur fractures? Locking plates and retrograde nails. Okay, well, everybody's using everything. But Jan, just do you think there are indications for locking plates where they perform better than the blade plate?
So currently I am using both locking plates, so angle blade plates, in different on types of fracture, on quality of the bone. As you could see, I like the angle blade plate, but I like also LCP in some cases.
Okay. Like in very poor bone quality, you like the locking plate? Yeah.
So.
Okay. Yes.
So, yes, I agree. The problem is, if you reconstruct the articular block, you must put the screws and wires not to compromise the place or the point for insertion of seating chisel. And insertion of seating chisel is a crucial point of the whole surgery. And if you know some tricks, it is not so difficult.
Yes, in the back. A high incidence of breaking? Okay, well, one of the reasons they break is because if the fracture is slow to heal, the plate's so rigid with the locking screws in it that there's tremendous stress on the plate. And so the plate rate, the failure rate of plates, I think, in locking plates is substantially higher than conventional plates, especially with delayed union. And short, for short, too.
It's really important to reduce the number of the fixing screws and to belong with the plate. They are the two mandatory things which should be respected if you are working more and more with the locking plate.
Okay. I think we have to move on. Thanks, Jan. It was very good. Excellent talk. Next,